As we know, the cardiac function is regulated by the autonomic nervous system. In many cases, cardiac autonomic dysfunction is a key mechanism in the development of several cardiovascular diseases. So let's begin with a case. This is a young man. He had several episodes of syncope. The normal ECG is showing here. But when the syncope occurred, you can see elevation in lead 2. You can see ST segment elevation in just beginning of the occurrence of ventricular fibrillation. Let's move to these slides. We can see very clearly here when the ventricular fibrillation occurred, you can see ST segment elevation in lead 2, lead 3, and lead AVF. Also, here, you can also see the AV block in the occurrence of angina. However, the cardiac coronary angiography is totally normal, so the diagnosis will be the variant angina. So we use antispasmodic therapy, but however, it failed. The patient still get syncope. So we have to put an ICD in this patient. I think what else can we do for this young man? Let's go to variant angina. Variant angina is not very common. It is characterized by coronary artery spasm, most common in Asian men. The clinic outcome is not that good. It can cause angina, myocardial infarction, malignant arrhythmia, sometimes even sudden cardiac arrest. In some patients, even antispasmodic medications are less effective. The mechanism for variant angina is very complex. Accumulating evidence indicates that autonomic activation involving both parasympathetic and sympathetic components plays a critical role in triggering coronary artery spasm. Parasympathetic activation can trigger spasm, especially during periods like nighttime, overeating, or during defecation. So autonomic medication might be beneficial for patients with variant angina. Cardioneuroablation is an option for vasovagal syncope and functional bradycardias. So I think cardioneuroablation may be an effective means for uncontrolled variant angina. So in last year, I have done a similar case. This is a 66-year-old man. He had 1 year history of nocturnal chest pain, worsened over 10 days. His AV episode of angina had occurred in the early morning, mimicking acute myocardial infarction. He has a ST segment elevation in inferior leads. We use very high doses of antispasmodic medications, but failed. The patient still had angina. These slides show the ECG during the angina attack. We can see very clear in lead 2, lead 3, and lead AVF, the ST segment elevation. However, the patient's coronary angiography show totally normal left and right coronary artery. When we use ergonovin perforation test, the patient can should totally occlusion of the left ventricular posterior branch. So we use 8 microgram nitroglycerin and 100 milligram natural peroxide to resolve the spasm. So I think this is sometimes dangerous for us. When we did GP ablation for these patients, we ablate 4 groups of GP in the left atrium. Then we repeat the provocation test. When you do GP ablation, we can get a heart block, as we show in the lower panel. When the asystole occurred, we should pace the ventricular to maintain the heart. After ablation, we repeat ergonovin provocation test. However, we use the same dose of ergonovin. We can still introduce spasm, but it's not that severe, and we did not see any occlusion in the right coronary artery. The spasm of the patient was resolved with 400 microgram nitroglycerin, but we did not use nitro peroxide. So the dose for this drug is much less compared to pre-ablation level. So we measured ERP of the AV node before and after ablation. So the ERP of AV node is much less post GP ablation. The time to onset of spasm is also delayed. The drug doses for resolve the spasm is also decreased. The symptom after GP ablation, it has no symptom after GP ablation when you do repeat the provocation test. The ST elevation is not observed after GP ablation. So when the patient discharged from our hospital, we give him a wearable ECG device for self-monitoring at home. During the follow-up, we can see the average heart rate is increased. The HRV index showing that the low frequency, which is reflecting the sympathetic activity, is decreased, and the high frequency, which is reflecting the parasympathetic activity, is also decreased. But the low frequency to high frequency ratio is increased. So this patient during follow-up has not any angina episodes in 14-month follow-up. At the third month after GP ablation, we encourage him to discontinue his antispasmodic medication, but the patient has no recovery of angina. We report this case in European Heart Journal case reports. So after that case, we have done many cases. This is case 2, case 3, case 4, until case 16 or 19. All the patients with variant angina show the same result. In many cases, after GP ablation, we did not induce spasm at all. Even in the patients whose spasm has occurred, we use much less drug to resolve. I think this result is very encouraging. We measure the HRV index and angina frequency and all other index showing the same result. After GP ablation, the patient has no angina. Some of the patients discontinued all his medications, even at 3 or 6 months. Here is our conclusion. Cardioneuroablation offers a new treatment option for uncontrolled variant angina. I'm responsible to conventional drug therapy. The effective result of GP ablation may be related to the inhibition of autonomic activity. Thank you.